Hey, Dennis.
Hey, three times the charm.
I guess so. I'm thinking. I'm starting to think you just enjoy my company, which is cool.
No,
That's fun. So,
I do.
well, I'll take that as a compliment then.
Yeah.
Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Dr. Van Wyk, and we are talking about paroxysmal sympathetic hyperactivity. How are you doing this evening, Dr. Van Wyk?
I'm doing great, Dennis. Thanks for having me back. It's a pleasure to talk to you again, as well as the audience.
Outstanding. I appreciate it. So this is definitely one of the first times I've been talking about this, the PSH. If you wouldn't mind taking a minute to just kind of explain what is it and how does this happen when it's associated at least with TBI?
Sure. That's a great place to start, and I agree with you. I think that this is one of these zebras, so to speak, in terms of complications for TBI. Not in the sense that it doesn't happen all that often, because as we'll discuss, it can happen in up to about a third of TBI patients, especially the severe category. But it's just one of those things that we don't discuss very often, or at least haven't up until this point. So I thought it might be an interesting topic to bring up, because I didn't think a lot of the audience members would have a whole lot of experience with this. But when we talk about paroxysmal sympathetic hyperactivity, what we're really talking about is a condition that is associated with brain injury. It can be associated with other conditions. It's been reported with certain types of brain bleeds, like subarachnoid hemorrhages, also with brain tumors, but most commonly associated with traumatic brain injury. And it results in discrete, transient, and oftentimes recurrent episodes of symptoms like hypertension, tachycardia, tachypnea, fever, sweating, and then something called dystonia too, which is an involuntary movement disorder that involves some posturing or twisting of the limbs and the body in some cases as well. And this is something that when you witness it, it tends to come on very, very quickly and suddenly, and it's often stimulus induced, as we'll discuss a little bit later. I think there's often a certain activity or group of activities that will bring on these episodes with the aforementioned signs and symptoms in about 3/4 of patients in whom this manifests. And then the other thing that I think is worth mentioning too is paroxysmal sympathetic hyperactivity is a fairly new agreed upon term for this. And if you go back and you want to look through the literature and comb some additional information about this condition, you have to really look for some other names. And one source had indicated that at one point there were up to 31 different names for this condition, but some of the more common ones previously used were things like autonomic storm or sympathetic storms, autonomic dysregulation, acute midbrain disorder. There's a whole host of them, but we unified it a number of years ago under this heading of paroxysmal sympathetic hyperactivity. But if you see those other terms, it's referring to the same condition. In terms of how does it happen and why does it happen, I think it's important to briefly kind of break down the autonomic nervous system, or the part of the peripheral nervous system that is responsible for controlling automatic body functions. So you and I don't have to think about things like breathing or changing our heart rate based off the different activities that we're involved in, changing our pupil size based off of the amount of light or absence of that's in a given environment. We take that sensory information and we send that to the central nervous system, and it creates a response that then goes out to the peripheral nervous system to change those things for us, so that we don't have to consciously do that ourselves or think about doing it. And the autonomic nervous system is broken up into two different categories. And the first one is the sympathetic nervous system, which is probably more commonly known as the fight or flight system or response. And this is what increases our heart rate in order to get more oxygen to skeletal muscle. It'll dilate your airways, your bronchioles to increase oxygen exchange. It'll dilate your pupils to allow more light in. So this is the the system that typically kicks in when you're in trouble, when you're injured, when your life is in danger, when you're under a lot of stress. And it's a way that the body basically kicks in all the systems that you need to help survive some type of stressful or injurious incident. On the other side of that, you have what's called the parasympathetic nervous system, or the rest and digest system or response. And this is the side of the nervous system that's going to shut down when the other one is active, because it's cutting off basically energy and supply to systems that you don't need in stressful situations. So things like your digestion, for example, or the ability to increase output from salivary glands. You just don't need that in a survival situation. So that part shuts down. But when you're resting, this is the part that takes over and allows those processes to occur. And this is the side that also will do things like lower your heart rate or has a role in lowering your blood pressure. So when we talk about paroxysmal sympathetic hyperactivity, now having that sort of brief overview of the autonomic nervous system, it starts to make sense about when we talk about what happens in brain injury and why we see these discrete and recurrent episodes. And there's two chief ideas that sort of underlie the pathophysiology of PSH. And the condition itself is not wholly or completely understood. Neither one of these completely explains it, but the first one is what's called the conventional disconnection theory. And the idea here is that the excitatory centers of the autonomic nervous system are located in the brainstem, a structure called the diencephalon, which essentially is your thalamus and your hypothalamus, in the spinal cord. And activity in those areas is modulated through relay pathways that connect to other parts of the brain, higher up structures like your orbital frontal cortex or your insular region, the temporal lobe, the amygdala, the hippocampus. And that when those areas of the brain are damaged, because the excitatory centers are much deeper and more centrally located, so it takes a very severe injury to injure those parts of the brain, while the other ones are much more frequently injured and easily injured. But if you damage some of those relay pathways, you get a loss of control or modulation of those excitatory pathways, and as a result, you get this sympathetic hyperactivity that kicks in periodically. The problem with this is that you really have to injure most of or all of those relay pathways in order for this to occur, because if you've got one that's working, it's probably going to have some type of inhibitory or modulating effect on those excitatory centers in their output. So that's where the excitatory inhibitory ratio modeling or model came in. And it involves the first part of the conventional disconnection theory, and again, that you lose inhibition of sympathetic outflow after injury from those excitatory centers. But the other thing that this postulates occurs is there's a loss of ability to modulate afferent sensory info, and that comes in the form of something we call allodynic tendency. So what does that mean? That basically means that any sort of external stimulus that is applied, even if it is not a painful or noxious stimulus or a dangerous stimulus, is interpreted because of damaged pathways as being dangerous or painful. And the result is that you get a response from the brain and the spinal cord that basically results in that sympathetic surge because it is interpreted as a painful stimulus even when it's not. So simple things like moving a patient or suctioning a patient can induce a paroxysm of sympathetic activity and create the group of symptoms and signs and symptoms that we just talked about.
So, these signs and symptoms that we just went over, I mean, they're pretty generic as far as possible causes. Things like pain can cause them, a lot of them. So how do I differentiate? How do I come to the conclusion that he has PSH and it's not a herniation, or it's not pain or discomfort, or he's just becoming light on a medication?
Good question. Good thought. I'll illustrate this with a little clinical vignette, because I think that's helpful in answering the question and going through some of the differential for this, as well as how to tease out clinically some of the features or non-features, so to speak, of PSH and help you determine whether or not that's what's going on with your patient. But imagine, for example, you've got a 27-year-old male who's involved in a vehicle accident, and we're about 30 minutes from the onset of injury, had to be extricated, and your initial exam shows responsive pupils. You've got a good gag. You don't have any response to voice, but you get withdrawal to painful stimulus or noxious stimulus. So you do your initial assessment, you make your initial interventions, you're able to move the patient to a secure location, start doing your reassessments, your more detailed assessments and interventions. And a couple of hours in, 10 to 12 hours in, you're doing some nursing care, and you notice that when you do this, you get a change in your vital signs. You notice that the patient becomes very, very sweaty, and that their heart rate starts to pick up above 140 beats per minute. They become hypertensive where they weren't before. Their systolic is now greater than 160 millimeters of mercury, whereas before it was a bit more in the normal range, 120 to 130. They get tachypnic. They go from a breathing rate, a respiratory rate of low 20s to 30s, and maybe they get a fever as well. You see a temperature now that you didn't have before of 38.3, which is about 100 degrees Fahrenheit. And maybe they have some of that dystonic posturing that we were talking about before. And this lasts about 5 minutes, and then you make note of it, you take note of it, you talk about it with your teammates, but it went away, and everything seems to go back to the way it was. And then an hour later, you do another intervention or check, and the same thing happens. And this time it lasts a lot longer. And now you're scratching your head thinking, what's going on here? And is this some of the other complications that we more commonly think about when we have a TBI patient? You probably should think about these other things first, because a lot of them are going to be more common, and in some respects they're going to be more immediately life-threatening than PSH is going to be. But you asked about elevated intracranial pressure, so you can absolutely have tachycardia and hypertension associated with pupillary changes as well, associated with elevated ICP. One of the differences, though, I think, is that if you see dilated pupils, for example, with PSH, you're going to expect that to be on both sides, because this is a systemic process or systemic effect. Whereas with increased intracranial pressure, it's going to be one side or the other, depending on where that brain tissue is shifting and compressing cranial nerves to cause that dilated pupil. Along with that, you're probably going to look for changes, focal changes in the neuro exam. Were they moving one side, and now they're no longer moving that side as these changes are occurring? This is where optic nerve sheath diameter might help you too. If you've been tracking optic nerve sheaths and those have been fairly stable, and you check them again and they haven't changed much, that could be an indicator that this is something other than ICP that's driving this change in your exam and your vitals. The other one would be your Cushing's reflex. So I've talked about this one before, and your Cushing's reflex generally starts as hypertension and tachycardia, which could look very much like an episode of sympathetic hyperactivity. But as that pressure increases and that herniation worsens, that's going to transition over to hypertension and bradycardia, which you would not expect to see with PSH. You do not get any parasympathetic activity with paroxysmal sympathetic hyperactivity. That's something that would drive you away from that diagnosis and make you think that something else is happening. It's going to be strictly hypertension, tachycardia, and the other signs and symptoms that we talked about. None of the parasympathetics are involved with that. So I would think something else there. Other ones that you might worry about would be seizures. Certainly, if you've got the dystonic posturing, you look at that and think to yourself, maybe this is a seizure that's occurring, and the length of the episode is probably going to be what changes your mind about that. Most seizures, even in severe TBI, are just going to last a minute to two, and you're probably not going to see things like diaphoresis or tachypnea with seizure activity. And again, for a PSH episode, those can last up to 20 to 30 minutes, which it could be a seizure, certainly, but that's a long time for a seizure to occur. And it's probably not going to respond completely to the seizure medicines that you would administer in that situation either. Sepsis in our vignette, probably a little bit early for that, but certainly with tachycardia and tachypnea, you could start thinking about that. Fever as well, if that's present. But you're probably going to expect low blood pressure in that situation, whereas with PSH, you're going to have higher pressures. Pulmonary embolus is another one. A minor PE can present with tachypnea and tachycardia, which could be hard to differentiate. But a more severe PE, you're going to expect to have some hypoxia with, which you won't get with PSH. And then spinal cord injury is another one, because spinal cord injury coexists many times with traumatic brain injury. The difference is that kind of in the classic spinal cord injury scenario, with a full bladder, for example, or some other stimulus that induces tachycardia and hypertension, as soon as you recognize what that stimulus is and withdraw it, you oftentimes get a rebound in the parasympathetic response, which will shift you in the opposite direction. So they become hypotensive, oftentimes with spinal shock, neurogenic shock, and may even have a drop in heart rate as well. So there's definitely a parasympathetic component in spinal cord injury when that's driving these types of signs and symptoms. But you won't see that in PSH. It will be purely sympathetic overactivity that's driving that, if that makes sense.
Oh yeah, absolutely. Now some of these signs, they can be fairly subtle, I would think. Is it worth just calling telemedicine and having a specialist kind of sort this out for you?
Definitely. There's many reasons to do that. One question would be, because I mentioned earlier that, some of the other complications of TBI are more common and immediately dangerous. That's true, but as in some individuals, the paroxysmal episodes are frequent and they can be very long in duration, and you can have a lot of difficulty getting them under control. So if you go down your list and you think that it's not X, Y, and Z, but it could be PSH, I think that's worth making a call, because I imagine we'll get to it here shortly, but we'll talk about some of the interventions that you can make to try to get these under control. But it can end up a bit of a balancing act with some of the other things that you're trying to do for a patient in TBI. So managing the medications especially can be a little bit tricky, and you're going to want a good plan for that. So that's where your neurosurgeon or your neurointensivist that encounters these on a regular basis is going to become really, really helpful to you.
Great. So since we kind of teased it already, what can we do for treatment?
Yeah, good question. So the best way to describe this is both in terms of non-pharmacologic interventions and pharmacologic treatment. So, and believe it or not, while there are a number of medications that are used to treat this in the ICU setting, like propofol and dexmedetomidine, you're not going to have those in the field, of course. But a number of the other medications that we use are available to a lot of medics. So we'll talk about that here in a moment. But in terms of non-pharmacologic interventions, one of the things I mentioned earlier is that there is oftentimes a triggering event for this, and it's usually some type of nursing intervention. So turning, bathing, suctioning have all activated paroxysmal sympathetic hyperactivity in brain injury patients. Other things like noise can do that as well. Loud noises have been reported as setting off PSH. So with that in mind, if you can identify certain triggering events, you can do your best to avoid those. If it's a nursing intervention, you may not be able to do that. So the best thing to do there is to try to bunch your nursing interventions together as much as possible, so that you're not changing a line and you're not bathing or cleaning the patient or changing a bandage. And then an hour later, you're doing something else like suctioning. Try to batch that together as much as possible to limit that external stimulus that's causing the PSH to occur. And then this is a tough one too, I know, in certain environments, but if you can limit the amount of noise that the patient is exposed to, that may also be helpful. If it's appropriate and it's available, some type of ear pro, or just putting them into a quieter part of of wherever you're located may prove helpful.
Sorry to interrupt you, but
sure.
You're talking about noise and things like that. Do you think PSH can be, the patient can be more sensitive to it if they're on ketamine?
I think that's possible. Honestly, I don't. I have not used ketamine very often in my patients in the unit. We have other agents that we use, but anything that will reduce the body's ability to accept or tolerate a stimulus, especially in this situation, could certainly worsen or make episodes of PSH more likely.
Okay, so maybe something, if you're going to control pain, do you think an opioid, obviously the right dose and under advisement of somebody else, but maybe that would be a little bit better situation?
Yeah, I will tell you that opioids are one of the frontline or first line agents for treating PSH. You won't find ketamine specifically in a lot of those algorithms. So this is an instance where if you're interested in treating a couple of different aspects or problems that occur with PSH, an opioid may be preferential because it's certainly been reported and studied a little bit better than something like ketamine has. So shifting into that, then we'll talk about the pharmacologic treatments that are available for this, and that folks in the field may have immediate access to or be carrying, or also a couple of agents that are pretty cheap and widely available throughout the world that you might be able to find fairly easily. And really, when we're talking about pharmacologic interventions, what you're looking to do with your medication is to either decrease the sympathetic activity that's occurring, to block the end organ response to that sympathetic activity if you can't decrease the activity itself, or to slow the afferent sensory processing, or basically that sort of that hyper sensory response that's occurring and inducing that sympathetic surge, that allodynic tendency that I talked about a little bit earlier. A lot of times you can get away. I've heard of and seen a couple of cases where a single agent has controlled a PSH, but a lot of times it's probably going to require more than one agent, to be perfectly honest. And really what you need to do is you need to look at the specific signs and symptoms in your patient that are manifesting, because you won't get all of them all of the time. And you may not have all of them in any one given patient, certainly. But tachycardia, for example, is one of the fairly common ones. And beta blockers are typically the first-line agent for that. We don't generally carry those. However, agents like propranolol and other non-selective beta blockers are pretty readily available. So that might be something that you can ask for or find pretty easily if you really needed to look for that. And it can be anywhere, but it can be fairly low doses of propranolol, for example. 10 milligrams every 8 hours is a well-cited starting dose, and then you titrate, see your clinical effect in order to get that heart rate and blood pressure under control. Hyperthermia is probably going to be best treated with Tylenol, which you could give per rectum. Of course, you can use surface cooling measures as well. So the misting and fanning the patient is also appropriate if you need to do that. The rapid respiratory rates of tachypnea tend to respond pretty well to benzos. A long-acting benzo like diazepam, I know my medics carry that. If you don't have that, a lot of others will have midazolam if they don't have both. Either one of those is going to be appropriate, and there's no magic doses, unfortunately, for these. Diazepam, for example, 5 milligrams every 8 is a well-cited dose in PSH, but a lot of it is just going to be playing around with the dose and the frequency until you can get the episodes under control. And then, of course, opiates, like we mentioned earlier, are probably one of the key agents, or one of the most widely used agents to control these. And it works a couple of different ways. It's sympatholytic, so it does modulate sympathetic activity or sympathetic activity in the body. And it also reduces, because it's a pain agent, that allodynic tendency that we were talking about. So morphine seems to be pretty popular, and it seems to work in a lot of reports better than other agents for some reason. It's not real clear why. But small doses, again, something like 2 milligrams every 6 hours is probably a good place to start. You may need to increase that dose and the frequency, however, in your patient. And again, no magic numbers for that. It's really kind of a trial and error process. And fentanyl is another one that's appropriate as well too. Fentanyl has certainly worked. It doesn't get the same fanfare as morphine does, it seems, but it definitely works. I've seen it work before. So something just like 25 mics of a really low dose, or 50 mics, every 2 to 3 hours is probably appropriate for something like fentanyl as well. So, and then titrate that to effect. There's a number of other agents that I don't want to get into because most folks aren't familiar with them, including other providers. They don't use those medications unless they're in the unit dealing with refractory cases of this. But those are some of the agents I think that people could find or have available to them in their med pack that would help them treat these episodes.
Outstanding. I guess if there were some key takeaway points, like you were going to tell me on a telemedicine call or something, what would be the key things you need me to remember going forward to treat somebody?
The first thing is, as with a lot of less common or less commonly discussed conditions in medicine, is if you don't think about it, then you're not going to ask about it or make any interventions to try and treat it. So if people don't take anything away from this at all, other than, hey, I remember somebody telling me about brain injury and sympathetic hyperactivity at one point, then that's a win for us, I think, today. So it's something to kind of keep in mind. It's very much a clinical diagnosis, Dennis. There's no imaging technique or lab that's going to tell you definitively that this is parasympathetic hyperactivity. It's kind of going through your list of complications like we did earlier and saying this doesn't fit, so I think I can exclude this. And if at the end of all that you're still having these episodes and you're not sure why, then think about PSH and bring it up when you talk to your consultants on BTC and see if you can develop a plan to mitigate some of that while you're evacuating and moving that patient to a higher level of care. The other thing that I would say too about this, another good kind of take-home message is when you look this up, traditionally it's described as something that occurs in the subacute phases of brain injury. But there's a couple of reasons for that, I think, and there's a couple of reasons that I think it's also worthwhile discussing today, like we are. And that's because it has actually been described to occur acutely within the first day of injury, which could certainly impact some of our field providers that are trying to take care of and move these patients. So it's something that you certainly could encounter. And one of the reasons that I think it might be more prevalent in that austere critical care environment is because in the hospital, when we get these patients, they're very quickly started on various types of infusions, opioid infusions, like I mentioned, propofol, Precedex, and other agents that would help keep this in check. So one of the reasons I think that this doesn't pop up earlier in some cases is because they're already on agents that help keep it suppressed. And as we start weaning them later on, as the patient's brain function starts to improve and we're able to withdraw some of those interventions, I think that's one of the reasons that you start to see it manifest, because it's certainly been described as its peak incidence is typically between 9 and 13 days, as I recall, and it can last out to 160, 180 days in some of these patients. So it's something that sticks around for a while. But that's one of the reasons that I think we might encounter it a little bit more frequently if we're looking for and thinking about it than some of the other providers that work in hospital and well-resourced settings might. The last thing I would say, too, is that there is some data, there's some conflicting data, but there is data to suggest that allowing this to go untreated or to occur frequently can have detrimental effects to a healing brain. And there's certainly reports of worsened outcomes, Glasgow outcome scale scores in brain injury patients who have sympathetic hyperactivity. So treating this is probably in the patient's best interest, and treating it as early as possible, if you start thinking about it, and you can't ascribe it to anything else, is probably going to help limit some of that secondary brain injury. Why does that happen? Hyperthermia, we've talked about that in some of the prior TBI talks and guidelines. That's very bad for an injured and recovering brain. So hyperthermia with this condition can certainly worsen it. And then just that surge in catecholamine. So dopamine, norepinephrine, epinephrine, those types of agent or neurotransmitters, when they're increased, and they can be increased 200 to 300% is normal in some of these PSH folks, that can have a detrimental effect on recovery as well. So it's a good idea to try and treat this early. And I've mentioned brain problems or brain complications or nervous system complications more specifically that can occur, but this can have non-neuro complications as well. If you're sweating a lot, some of these patients sweat a lot. You can have electrolyte disturbances. You can have low sodium, for example, which has a whole host of problems associated with it. And if you get dehydrated like that, that can cause rhabdo, and it can affect the kidneys. You end up building up acids in other ways. You get myoglobin levels that increase to cause kidney injury. If you're tachycardic and hypertensive for extended periods of time, that can lead to various cardiac abnormalities. And if you've got a vented patient, you probably do. If you've got a severe TBI, if you've got ventilator complications, or you could have ventilator complications that arise from this condition. They get tachypnic, and if you're giving some PEEP or some pressure support, they could have air trapping as a result when they get into those tachypnic episodes. You may have to think about and adjust your ventilator settings to account for that. All of this, I think, is sort of underscores that previous comment and discussion about getting some VTC assistance with this, because it can get very tricky, even in a patient who may just have an isolated brain injury, let alone other complications from polytrauma. But this can get very, very tricky and affect other systems as well.
Cool. Hey, thank you, Dave. It's always a pleasure.
No, thank you for having me back, and it's great talking to your audience, and hope to do it again in the future.
Absolutely.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.